right, let's get started. It's a great pleasure to introduce our today's speaker, Richard Ng. He is an associate professor and the director of clinical research at Children's. He is originally from South Africa. He was born in Johannesburg, did there his medical training, did his residency, and became board certified in South Africa. He's also board certified in the UK, and he's quite a world traveler, as I heard this morning. After South Africa, he went to Duke for 8 years, and eventually ended up being here since 2011, and he's a real expert in things we all don't really know much about. He knows everything about congenital heart disease in pediatrics and adults. I'm looking forward to his talk. Thank you.
Thanks very much, Tobias. Good morning, everyone. Welcome to this grand rounds on this fine, chilly Monday morning. I would just first of all like to thank Vesna and the team that organized our wonderful Christmas party, our holiday get-together on Saturday night at the museum. For those of you who were there, I'm sure you will all agree with me that it was a wonderful, wonderful occasion, sharing times with friends and colleagues and children having a wonderful time. So thank you very much, Vesna, on behalf of everyone. This topic I chose, remembering Dr. Francis Fontaine, the anesthetic implications of the Fontaine circulation, because it's a very important topic for us. We don't always get to see patients with it, but when we do, there are a lot of things that are going on. We don't always have a thorough understanding of the pathophysiology of the disease process of single ventricle anatomy. And more importantly, these patients, we need to be mindful of the type of life that they live. We have no idea of what they've gone through, the number of operations they've endured, the difficulties they have with their ability to get around, their exercise tolerance, their ability to get insurance or hold down a job or even think about family planning. So we need to be very mindful when we take care of these patients that there's a lot going on from the pathophysiology point of view, and what we do does make a difference. And so I always feel it's important to have a strong pathophysiology basis, and that way we can inform on our anesthetic and plan the best way forward for these patients. So what I hope to do today is tell you a little bit about the anatomy of the Fontaine circulation, and then we're going to describe the extra cardiac long-term consequences of the Fontaine circulation. Then we need to understand why over time this Fontaine circulation fails, and then try to give some points as to the safe way to plan an anesthetic for these patients in various stages of their disease process. But this year is a special year for us and for many patients in the world with single ventricle anatomy who have a Fontaine circulation, because we lost a pioneer, a man who devised an operation that has given so many thousands of patients so much hope and such a longer life than they would have had. It was in 1968 that this operation really first was tried and published, mostly in 1971. There were one or two reports earlier on, but this came to pass as an option for which had otherwise been a very difficult anatomical lesion, and that patients really didn't survive long-term from prior to this time. And so, we give thanks to a man who was pretty humble. He was a cardiologist and a cardiac surgeon from Bordeaux, France. Him and Baudet wrote their seminal paper in 71, and he, although this is an operation named after him, he never thought it was one of his biggest triumphs. What he liked to be remembered for was the creation of the European Society of Cardiothoracic Surgery, how he brought the cardiothoracic surgeons of Europe all together and improved their group ethos and education. So a very, very nice man who we've lost this year. So the first op was done in 25th of April, 1968. It was described in 71. And really the principle of it was surgery transmits the whole vena cava blood supply to the lungs, while only oxygenated blood returns to the left heart. It was done in tricuspid atresia patients, so there was really no right ventricle to talk of. And so this way, the left ventricle was pumping the blood through to the lungs with its own kinetic energy, without the sort of extra force of a right ventricle to get blood into the lungs. And the right atrium in these patients was ventriculized. It's a word he used in one of those papers, because many of the tricuspid atresia patients have a downward displaced tricuspid valve more towards the apex of the RV. So there was some trabeculations in that atrium, and they felt at this time that that was going to be important to try and augment pulmonary flow. And I think the important point about this is Fontaine and Bordeaux really realized at the beginning that they emphasized it was not an anatomical correction, but one that was physiological. So where are we sort of 50 years later with this procedure? Surgery has improved from about a 10% outcomes in the first decade of life in the pre-Fontaine era to nearly 90% in more recent years. And it's really expected that 70% of patients, we've been shown over the long-term studies that these patients have survived for 25 years after surgery at least. So let's get on to our first objective, understand the anatomy of the Fontaine circulation. And it really all starts with what is single ventricle anatomy. And, you know, we may have ideas about it, we don't always know about it, but really the definition is any patient with congenital heart disease who is staged to the Fontaine circulation. And in 2018, we would expect that these patients, when operated on at birth, 75% of them are going to live to adulthood. Such is the advance in the techniques of this procedure and the outcomes in terms of cardiology, anesthesia, and of course our surgical colleagues. So what is univentricular anatomy? It's a big basket full of diagnoses that even the best surgeon in the world cannot fashion a patch to either create a two-ventricle repair. Sometimes patients are born without a left or a right ventricle. You can have double outlet right, double outlet left, double inlet left, double inlet right. And so early on, even in utero, with the first ultrasound diagnoses of these during pregnancy, cardiology and surgery decide there's just no way we're going to be able to make a two-ventricle repair out of these patients. And so the prevalence of single ventricle anatomy, the live birth prevalence is probably about 35 per 100,000. In the USA in 2010, there were 2.4 million patients living with congenital heart disease, and that includes 1.4 million adults and about 1 million children. Of that, there's about 20,000 adults with single ventricle anatomy, and this accounts for about 1.5% of the adult congenital heart disease population. And so very early on, surgery decides, right, we're going down the single ventricle route. And there's really a three-step process to this. The first step is it really depends on the pulmonary blood supply. It's either inadequate, and they need a BT shunt. It's either too much, and they need a band. Or there's inadequate systemic flow from a diminutive aorta, and there's no left ventricle, in which case they would undergo a Norwood. The next stage of this is a cavopulmonary anastomosis, or the so-called Glenn procedure, where the SVC is anastomosed to the pulmonary artery, and this occurs anywhere from about 4 months to 8 months of life. We seem to be doing them earlier and earlier. Thereafter, it moves on to the classic so-called Fontaine operation, which is a total cavopulmonary anastomosis. And you'll notice here that in this picture, the right atrium has really been completely excluded from the heart, and the blood is really flowing from the IVC up to the pulmonary artery with the SVC. And very often there's a small fenestration here which allows some pop-off to augment cardiac output into the common atrium. So those are the three operations. Now you can't really go from stage 1 immediately to stage 3 at birth because the pulmonary vascular resistance is too high. And so it needs time for the pulmonary vasculature to grow and the PVR to drop so that this operation can become successful. So that really is the summary, and we take care of the patients in between. But most of us will meet the Fontaine patient later in life as a teenager, as an adolescent. And that's where I think this topic has relevance for us all here this morning. We will meet them later on. So let's get back to the first operation by Fontaine. You'll notice here with that ventriculized atrium that I spoke to you about, what they really did here was they created this right atrium, and you can see some valves in it. And they baffled the blood to really go to the left pulmonary artery, and the SVC went down to the right pulmonary artery. They felt that those valves were important initially. But over time, you can see on the top left would have been the first Fontaine operation, which we've just described. Various people made modifications to these. There was the Kritzfer modification, and became the Bjork modification. But these bottom ones really are where we are. These are the patients we tend to meet today. Many of these patients did well for a while but didn't survive. Natural selection from operations and improvement resulted from the early 90s, late 80s, that these operations became much more standard of care. Marc Delaval from Great Ormond Street created the internal baffle with a little fenestration here, which was really a big step forward. But the big problem with that operation was there were lots of suture lines in the atrium, and over time, these patients develop intractable arrhythmias. Then they went on to the extracardiac total pulmonary anastomosis, which is the one favored by most surgeons in the modern era. And you can see this little fenestration here as a pop-off in the presence of a high pulmonary vascular resistance at surgery, which will allow some augmentation of cardiac output as that circulation becomes more, as the patient gets used to their circulation. And this is one which would be done a lot of in adult patients. Often it's a Fontan conversion from one of the earlier forms. And here you can see some cryoablation lines which are done to try and offset some of the arrhythmias that these patients get. So the type of surgery does matter, and that's, as again, part of the pathophys. If you understand what operation they have, it's going to allow you to understand how perhaps you'll be able to better give an anesthetic. The big problem with this surgery is that it creates this big resistance where these currents all come together. We've got the IVC blood here, pulmonary artery here, SVC blood, left pulmonary artery on this side. And there's not often a lot of to and fro movement that can go really left or right for the blood. So very often surgeons have been offsetting these arteries or these veins to allow really IVC blood to preferentially sort of go to the right lung and the SVC blood to go to the left, or vice versa, depending on the anatomy and what the favorable anatomy looks like at the second stage. So when they're doing that SVC to pulmonary artery anastomosis, they're really thinking about where the IVC is going to be attaching to the PAs. And there's been a lot of work done with this to try and minimize the amount of resistance that those flows create, because you may have an absolutely perfect operation, but if there's some resistance to flow there and the systemic venous pressure starts to increase, that's what leads to all the problems down the line for these patients. But what we do know is that these contemporary techniques have improved long-term outcome. If we take some of the earlier forms of the Fontan surgery, the sort of classic one by Fontan here, there was a 65% survival at 20 years. The Marc de Laval lateral tunnel, about 85% at 20 years, but with the risk of a lot of arrhythmias over time. And now the more modern one, which is the extracardiac conduit, with a 95% 15-year survival rate. And you can see here over time with these Kaplan-Meier survival curves, the probability of survival with the extracardiac is right at the top, where the AP sort of window, the aortopulmonary Fontan by Fontan is the lowest. And also with arrhythmias, that's the most important thing. You can see freedom from supraventricular tachycardia, the extracardiac, because there's really minimal suture lines on the atrium, they have far less arrhythmias than the other forms of the surgery. So we need to step back a little bit and say, how did these pioneers decide to do this operation? What allowed them to think it was even possible? So if we look at our history of congenital heart disease, it was Helen Taussig and Alfred Blaylock in 1945 when they described the subclavian to the pulmonary artery shunt that really gave a lot of promise for this specialty. Suddenly, blue babies were allowed to live because some pulmonary blood flow could augment the dark blood from the sort of anatomical reasons why these patients were cyanosed. So this was a major step forward. And at this time, there was a lot of comparative physiology being elucidated by our colleagues at the bench. And so they were looking at the amphibian circulation and mammals and fish and trying to consider how these various organisms lived. And there was a lot of work going on where colleagues were bypassing the right ventricle. By this we mean they were either ablating a biventricular model, they were doing cryotherapy and cauterization and completely destroying the right ventricle just to see what would happen. And this was work by Starr in 1943. And all of this comparative anatomical work was interesting because it really showed that in a biventricular system, if the right ventricle was ablated, the pulmonary artery pressure still measured about 25/10, which was very, very interesting because at that time, the thought was that the right ventricle was really needed to pump blood through the lungs. And it was clear now that it wasn't needed necessarily. You'll see some of these earlier pictures from 1950 and back into 70 where they started to dissect out the hearts. And the reason why this is so is that the left ventricle has got fibers which extend onto the right ventricle. And so when the left ventricle contracts, it's actually augmenting right ventricular contraction by about 20 to 40%. So even if the whole right ventricle is destroyed, there will still be some flow of blood through the right side of the heart just by the mechanism of these muscles and the squeeze that it's doing from the apex out to the outflow tracts. And very interestingly, late 1958, William Glenn and his colleague Patino, they started to describe mechanisms of, once they had all this knowledge and they realized the right ventricle was not needed to augment pulmonary blood flow, they started to experiment with the SVC onto the pulmonary artery in animal models. And you'll notice experiment number 28 from some of their work. Here on this picture we have the right lung, which is being supplied from the IVC, and we have the left lung, which is being supplied by the SVC. So here is the sort of a Fontan circulation that they were working on very early. But they did find that there was intractable edema which developed in the lower body in these patients. So you can see how each step along the way, we stand here on the shoulders of giants before us who have done the hard work. And so this is where Fontan and his colleagues took some of this earlier work by Glenn to say, okay, maybe we can create a total pulmonary anastomosis. And you can see from 58 to 68, that was another 10 years later before it actually came into fruition. And as I said to you, the contraction of the LV provides about 20 to 40% of RV function. And in the modern era, we see lots of work on this from those 1950s and 1970 pioneer work, notably Andrew Reddington. You'll see a lot of work by him in the current era with nice mapping showing how these fibers are intimately related between the left and the right ventricles. So we can get some really nice pictures today which show us exactly the work that was done in the 50s and the 70s. So, if these colleagues of ours have shown that you can get rid of the right ventricle, this led people to think, okay, maybe there's another function for the right ventricle. It doesn't need to pump blood through the lungs. And in the 80s, Sandy Fury and colleagues put forward the thoughts with evidence that the pulmonary circuit really contributes an additional 10% to total peripheral resistance. They were able to quantify this. And that meant that the left ventricle was very easily able to handle that extra resistance of the pulmonary bed. So we don't need the right ventricle to pump blood through the lungs in the presence of a normal pulmonary vascular resistance. And in fact, what they went on to say is that the main role of the right ventricle is actually to keep venous pressure low. It's to stop pooling of venous blood in this large capacitance of systemic veins. It's to prevent peripheral edema. That is the role of the right ventricle. And we all know that when you have right ventricular failure or tricuspid regurg, it doesn't take long before patients have massive livers and very, very severe dependent edema. So how did we get to the Fontan? Really what we've done is our pioneering forefathers in this field have created a fish circulation. That's what they've done. Let me just take you through it. At the first stage, an interatrial septostomy is done so that you really have one atrium and one ventricle. This goes to the peripheral resistance down in our capillary beds, the venous capacitance up to the lungs, that resistor, and then back via the pulmonary veins to the lungs with oxygenated blood. And so that's what it looks like. There's the IVC, there's the little fenestration, there's the pulmonary arteries, there's the SVC. We've created a simple circuit. And the only additional thing that the surgeons have done with the fenestration by Marc Delaval and colleagues was to have a little pop-off when the pulmonary vascular resistance gets too high. And over time, sometimes we close that. So most operations nowadays, they will do that fenestration, but we find sometimes it's closed even before you get back to the intensive care unit. It all depends on the circulation and the PVR, and it's the selection of the patients for this procedure that becomes very important. So let's move on to objective number 2 here. Does everybody get the anatomy? Any questions on the anatomy? Thank you. But please shout out if you have anything. So now we're going to describe the long-term extracardiac consequences of the Fontan. Slowly over time, a perfect operation starts to beget complications. And this is a meta-analysis which came out earlier this year. They looked at 34 studies, 7,000 patients, mean follow-up duration, 114 months with ranges. And really what happens over time is this Fontan circulation starts to fail in 34% of them, sudden death in 19%, and this is the bad one, and this is where it's important for us. 16% of those deaths are a perioperative death, either coming for cardiac surgery or non-cardiac surgery. And over 80% of patients who survive the Fontan surgery will be alive at 20 years. So that's what we have contemporaneously. And that's to remember that there's also been natural selection. So those patients with the most favorable anatomy have done well. And of course, we've lost many over the years who were perhaps not as favorable or had earlier operations. So as we move forward with the more modern techniques, we may find that the survival rate is obviously going to go up. Larry's asked me if I just got this little picture from my school books. It was a good one, Larry, but what it is it sort of shows a simple diagram of the human body, but with the little lines that were available, I thought it would be much easier to remember the complications or the changes in pathophysiology related to the anatomy. So let's start with the brain. Over time, these patients can develop occult strokes, decreased executive functioning. They can be thrombotic, embolic. They are prone to thromboembolic disease. We'll talk about that in a minute. They have an increased pulmonary vascular resistance over time with collaterals in the lung. They develop cyanosis, thrombosis, plastic bronchitis. In terms of the liver, with a slowly increase in the systemic venous pressures, they started to get passive congestion of the liver with increased lymph production and the sinusoidal fibrosis. And slowly they can develop cirrhosis and even hepatocellular carcinoma over time. They get protein-losing enteropathy, where they sequestrate proteins into the peritoneal fluid or out of the gut. They get varicose veins, not only in the legs, but they can develop these varicosities throughout this organs as the liver starts to fail. They develop ascites. They have renal impairment, and the minute they start to get renal impairment, they start to get hepatorenal dysfunction and pulmonary renal dysfunction. So the minute the kidneys start to go off, it seems to augment and accelerate the dysfunction of the other organs. Portal hypertension, portopulmonary hypertension, and splenomegaly. They get arrhythmias and cardiac failure. So there's a lot that goes on over time because of the Fontan circulation. And what the Fontan really pulmonary circulation, it creates over time a systemic venous hypertension. As I've explained, the right ventricle is there to keep venous pressure low so that we can fill the lungs very easily. And they get this hepatic congestion as the SVC and the IVC pressure goes up, so the transpulmonary gradient across the liver goes down. And they start to get less pulmonary blood flow getting through. And this really begins on the day the Fontan operation is done. On that day, the venous pressures rise abruptly by about 2 to 6 times baseline. And so everything that cardiologists do and surgeons do is trying to select out the best patients who will benefit from this procedure. And so we spend a lot of time in the cath lab measuring all these numbers before they go for the Fontan. And this just shows you what happens in the lungs over time. You have these capillary beds, which would be normal on the left here, and then you suddenly start to get these AV malformations where the pressures are just so high, they start to break down the normal arborization and just take the path of least resistance. So that can invoke less blood being exposed to alveoli, they start to become cyanosed, and they can also start to get some volume overload as a result of those short circuits. And then we get a concept which is known as the Fontan paradox. Normally what we have is low IVC pressure into the right atrium, -1 to about 4, a step up in the right ventricle up to pressures of about 20, 25, and then we have pulmonary artery pressures about 25 over 10. But what happens in this situation, the paradox, is instead of having a low venous pressure, the venous pressure starts to rise, but there's no ventricle to give it that little kick. And so the blood reaching the lungs is at a lower pressure, normally less than 15 millimeters of mercury. And what does that do over time? Well, it results, as I explained, in a loss of that transhepatic venous pressure gradient, which augments easy flow into the hepatic veins, into the IVC, passive distension, portal venous hypertension, and then we start to sequestrate proteins into the gut. And antithrombin 3 is a very small molecule, so the minute that molecule starts to get lost, they are prone to thrombosis. And so many of these patients are on anticoagulants. We start to get altered gut blood flow, low cardiac output, and persistent hypoxemia and inflammation just augment those injuries. And this is an MRI of what the Fontan circulation or the circuit looks like. You'll see here that this is the IVC. This was a fenestration. It's been closed with a little metallic Amplatzer device. And you can sort of get the sense that the IVC is a little bit small. And the way that this Fontan circuit lies, this IVC blood is preferentially going to the left lung. The SVC blood is preferentially going to the right. And this is not uncommon to see differences in sizes of the pulmonary arteries. And we'll spend a lot of time, the cardiac group, taking patients to the MRI to quantify some of this, to see what can be done. As people, as our cardiology colleagues start thinking about stents in various places to decrease resistance in the circuit to try and lower the pressures. That fenestration was probably closed. It may have been open initially, and then patients may develop strokes or they're desaturated, and so a decision is made, if the numbers are favorable, to perhaps try closing it. And invariably we close it, and a few years later they come back. Now they're starting to sequestrate proteins, developing plastic bronchitis, and we'll reopen it. So this is a dynamic process of trying to determine whether each individual patient can withstand the Fontan circuit and for how long. Another key point is that over time they develop very abnormal lymphatics. Because of these higher pressures in the liver, they create a lot more lymph, and there's nowhere for it to go. The pressures are high. The lymph drains into the SVC at a negative pressure. It really is there's no pumps in it. It's just draining in there. So the minute you have a SVC pressure of 10 or 15 in these patients, the lymphatics, even if the thoracic duct is intact, it just won't drain. But very often the thoracic duct has been damaged in surgery through all the aortic arch work that they've had to do. And so you start to get these poolings here. You can see a supraclavicular pooling of lymphatics. Infradiaphragmatically, you can see also this is large pools of lymphatics, a very tortuous thoracic duct. And so these ducts start to take their own course, and they develop, you can see in the lung here, this very clear picture of lots of areas of lymphatics. And that lymph under high pressure starts to sequestrate into the alveoli. And so they start to get this proteinaceous casts which develop in the lungs. It doesn't happen in all patients, just in some, depending on their various forms of Fontan, and whether they have a dominant left ventricle or right ventricle. Those are often some of the things. Also, you can see pooling of ascites here as this lymph just tracks everywhere. So our colleagues are able to map this out by going into the groins and injecting lymph nodes with gadolinium and then allowing a phased time for this to sort of track up through the lymphatics. But these can also be very long anesthetics. They may take 10 hours sometimes as they try and get decent pictures of this. The idea being behind it, if patients have had life-threatening hypoxia from bronchial casts and plastic bronchitis, that they may be able to block off some of these ducts over here, just coil them, these lymphatic ducts, and stop the sequestration of that lymph within that lung. But it's going to go somewhere else. And so it's really like whack-a-mole. You block this one, and very soon you've got a collection of lymph somewhere else. But many of these patients live with intractable ascites where it all tends to sort of collect. Here's just another picture showing it too, some of these scans. That would be the airways, and you can see again in this picture how there's been diversion of this infradiaphragmatic lymph up to the right lung, which is all around the bronchus at this level here. And this just really is a diagrammatic form of it, showing the lymph channels and up to the thoracic duct, and how you can get these diversions to any part of the body where they start to create symptomatology. And Susan Begasi and colleagues have got this really nice picture of how you almost get this bronchial cast, which is a whole pulmonary tree, and these have to be removed under bronchoscopy. We've had one which we wrote up as well here at Children's Hospital some years ago. This patient actually on removal of this cast developed an intractable sort of shock state. We think there was a whole dissipation of inflammatory cytokines and probably some infection. Ended up on norepinephrine, epi overnight, and high antibiotics and steroids, and actually did settle. By the next day started to improve and has done well. So that's the we're now in the area of looking at the other organ dysfunction associated with Fontan. We've touched on the lymphatics, the liver, and now the liver more recently has become an area of interest, Fontan-associated liver disease. And the main reason is that even before the Fontan operation, at the first stage and the second stage during the Glen, there is congestion of the liver. Many of these patients have fibrosis already pre the Fontan because of these higher venous pressures, even at the Glen stage. And their cardiac function may not be favorable. So this is just a little bit of liver revision. Remember, the liver has a bilateral supply. We have the portal vein, which supplies about 70 to 80% of the blood. 20 to 30% comes by the hepatic artery, and that is a flux thing. It can shift a little bit. If the portal vein blood flow goes down, the hepatic artery blood flow can go up. But ideally, the gradient within that system, if you're starting to measure the pressures on the IVC side of this arborization through the liver, those pressures should be extremely low within the liver sinusoids. But unfortunately, with the Fontan circuit that you can see here, over time, that liver starts to get this nodularity, fibrosis, and cirrhosis is even possible with hepatocellular CA because the relentless rise in the IVC pressure. Venous hypertension, non-pulsatile blood flow plays a role. And then you've got the heart on the other side. Over time, the pulmonary vascular resistance changes. It can increase in these patients, and so they get a low cardiac output. There's low volume of blood coming to the systemic ventricle. They start to develop a low SVR the more the liver fails, and then they start to get liver hypoperfusion, portal hypertension, varices, splenomegaly, and cirrhosis. If we drill down a little bit further into the liver lobule, you'll see here again the bilateral supply. This is the hepatic artery. This is the portal vein. It arborizes through the sinusoids of the liver to these central veins, all ultimately linking up with the hepatic veins and then off to the IVC. Now, they talk about an increase in hepatic afterload because of the systemic venous hypertension. And the sinusoidal pressure increases because there are no valves, often greater than 5 millimeters of mercury. And the arterial buffer from the hepatic artery can help when the pressures get increased, but not when they're greater than 25 to 30 millimeters of mercury. And it's important to remember that when the single ventricle patient exercises, if they have a central venous pressure of, even in the best hands, 8 or 9, it will increase up to 20 to 30 during exercise. So these patients are encouraged to do exercise, but it's just very difficult for them because the lungs cannot handle that increase in cardiac output during exercise. And so what we'll sometimes do in the cath lab is we will, under surveillance, they will do what we call hepatic wedge measurements. They'll place a catheter into the hepatic vein, measure the wedge pressure, and then if that's up, these patients may need a heart transplant because that liver is going to fail, and sometimes even a heart-liver transplant combined. Now, what makes Fontan-associated liver disease so important is that we do know that many of these patients are lost to follow-up as they transition from children to adulthood, and the studies have shown that it's anywhere from 3 to 5 years. At some point, they're just not followed up and monitored. And so when they start to present to our adult cardiology colleagues, many of these liver changes have occurred. And this is the problem. The biggest problem is that Fontan-associated liver disease is often detected incidentally. And so what can be done? Well, optimize the Fontan circulation with anatomy. In the cath lab, coils, stents, trying to improve flow to the lungs passively. Physiologically, just ensuring that pulmonary vascular resistance stays low, treating coexisting conditions, obstructive sleep apnea, pulmonary vascular therapy. Sometimes they're on sildenafils, some modulators of vascular proliferation, compressions and venous stockings to try and augment venous return from the lower part of the body. And the next part is really preventing liver injury by pre-Fontan, avoiding any shock during any of those initial surgeries, protecting the liver, which our colleagues do in critical care, Hep A and B vaccines, and then post-Fontan, we don't know the importance of alcohol in these patients. Does it cause significant liver disease? Does it advance it? We still don't know that. Obviously, the vaccinations, avoiding hepatitis and obesity, hepatosteatosis, trying to minimize the reasons why the liver may stiffen up. And so this was a very sobering paper written in 1980, sort of 10 years after the first Fontan by Fontan and his colleagues, when they started to see some of the complications coming back in these patients. And they were very saddened by it, actually. The Fontan state imposes a gradual declining functional capacity and premature death after an initial period of often excellent palliation. And this was the incidence in 1990 of atrial dysrhythmias, very high, myocardial dysfunction in 71%, thromboembolic events, and large atria, hepatic dysfunction, protein-losing enteropathy. But they still were hopeful that there was a 70% long-term survival rate. And that's been shown that the single Fontan operation came out at about 65 over some years later. All right, we're getting into the last couple of objectives here now. So we're going to understand how the Fontan circulation fails. I've led up to that. But basically, it's a pulmonary volume overload over time. If we take this graph and we have normal biventricular anatomy, the pulmonary volume overload is really 100% at birth. That's the normal circulation. Birth, time. If we take single ventricle anatomy, a shunt is done. They try to limit the amount of pulmonary flow by the size of the shunt. By the time the Glen occurs, there's a drop in pulmonary flow. Then it's augmented again with the Fontan, and it's never really back to normal. It's always a little bit less just because of that stasis. But there's a subset of patients in blue who are the Fontan who never really achieve the same degree of pulmonary flow as their contemporary patients, as other patients. And so it's this group who go on to fail more rapidly and perhaps more severely. And the reason is their anatomy is just not as favorable as other patients. And that's where a lot of research still has to be done, is the signaling, what's causing the changes in these patients, why some do well and some don't do as well. But if we drill down a little bit further into why the ventricles fail, these single ventricle patients really have these changes in volume to their ventricles over the first, second, and third stage. There's often overload, overstretch, and then when they get to the Fontan, as that volume decreases, that ventricle starts to become deprived of blood. It leads to slowly, over time, a lower cardiac output with the natural compensatory mechanisms of increased SVR, renin, angiotensin, and slowly, relentlessly, sort of systolic and diastolic dysfunction. And the word they use in this situation is that ventricle starts to develop a disuse hypofunction. And we know that the ventricle needs to receive more than 70% of base flow in order to not become de-exercised or develop disuse hypofunction. And over time, as well, as the diastolic pressure starts to increase, the negative inspiratory effect or the negative filling effect of diastolic relaxation is lost in these patients. We do know they do much better with negative pressure inspiration. So everything we do in anesthesia tries to keep them breathing spontaneously, to drive fluid through the lungs and fill that ventricle. This was a very good review from 2015 by our colleagues at Boston Children's, and they show the difference between the Fontan physiology in a normal patient and one with a single ventricle anatomy. On the top graph, you'll see the left ventricle. We've got the resistance of our systemic circulation coming to the right atrium, low pressure. The right ventricle augments pressure, goes through the pulmonary arteries. But in the single ventricle anatomy patient, they've got the resistance of the systemic circulation. Then there's the resistance of the actual Fontan graft material itself, and then the resistance of the lungs. And so in the top one, you can see that if you're trying to augment preload, it's possible that you can give some volume which would help augment that right ventricle. The point that this article makes, for me, which was very interesting, the biggest problem in the Fontan circulation is that it's very hard to augment preload without augmenting afterload, because there's no extra pump to get that blood through the lungs. In this situation, if you're trying to augment stroke volume, because it's one single loop without that second pump, if you pour volume into this circuit, that ventricle just has to work against that volume. So in the Fontan circuit, you cannot increase preload independently of afterload. If you give them more volume, you're increasing both. And our knee-jerk reflex very often is, if BP is low, we just give a bit more fluid. But in the Fontan patient, that's perhaps not right. We should be looking for reasons why the cardiac output is low and augment it with inotropes, optimization of hemoglobin, calcium, other things, negative pressure, inspiration. i.e. ratios of ventilation. So really, the pulmonary microcirculation holds the key to the long-term outcome in these patients. And there's work by others that will say that the kinetic energy that's generated by that single ventricle is really not enough to help propel blood through the circuit. That goes against the 1940s and 50s work, but nevertheless, there's some evidence that the kinetic energy that is generated within the vasculature as that propulsion of blood is, that stroke volume is moving through it, that it's also the vasculature which is helping propel that cardiac output. And that's why when they start to get venous stasis in their legs, they talk about the muscle pump in Fontan patients. When they're walking and moving, the muscles moving in the lower body augment preload and try and get that blood back up to the heart without that right ventricle there to keep those pressures low within that systemic circuit. So really there are 4 types of Fontan failure in terms of the phenotypes. And this is the confusing thing. There's not just one form of Fontan failure. Some of them fail with a reduced ejection fraction, and so the care for them with heart failure patients is fairly similar. Those types of medications may be beneficial, but then there's times when there's preserved ejection fraction, and it's a diastolic dysfunction, in which case sodium restriction and diuretics are probably better for those patients. Type 3, there's actually normal function of the heart, but it's an interplay of the multiple abnormalities and the coexisting pathophysiology which we've gone through, the lungs, the liver, all the other things. And then there's a type where you can have normal heart function, but these patients, just for some reason, sequestrate much more proteins. They have the so-called protein-losing enteropathy and that plastic bronchitis we mentioned. And that becomes the challenge for our adult cardiology colleagues, is to determine when the Fontan is failing, what type of failure we see. And so that's why whenever we give anesthesia to these patients, we need to have a good cardiology friend. We need someone who understands this pathophysiology so that they can tell us whether these patients are optimized or not. You know, keep the BP up and give fluids and prevent hypoxia. It's seldom helpful when we see that in the chart when we've asked our cardiology colleagues if these patients are optimized for anesthesia. All right, we're into the last piece. I promise not to keep you much longer. But I find it fascinating, and I wanted to just share some of the stuff with you. So now we're going to discuss the anesthetic care of the Fontan patient. So let me try and just give you a little short video of what the ventricular blood flow sort of looks like in these patients. So I'll just orientate you because it's a short snip, but you can see a little bit of the IVC here. This is the diaphragm. There's a sort of bowel there, but if the diaphragms are probably here. This is the Fontan baffle at this point. You can see it sort of moving into the right pulmonary artery. There's a little fenestration at this point. The SVC comes down there, and then obviously that would be the right pulmonary artery at this point. So you'll see the sluggish flow swirling around in here, and those swirls are what are important to understand, that this flow of blood is seldom laminar. And there's 4D MRI evidence showing some of these problems which are emerging now. So just watch this. As you'll see there, the blood sort of swirls around. I'll run it a couple of times here. Can you see that? And there's a little bit of blood crossing over the fenestration. You can see the liver, it's engorged. Some of the spleen and the kidneys out to the left there. So that's really what's sort of happening on the inside of the patient. But what we find very helpful is just to consider the heart in these patients. It's single ventricle. And this is a very nice article by Chassot and colleagues where they divide the atria, the valves, the ventricle, the outflow tracts. Just consider all those elements. Are they working well? Are there any stenoses? Is there any element of this which could affect the anesthetic? Are there arrhythmias? Is there ventricular dysfunction? Are there any stenoses? And all congenital heart disease has these 4 things in common. Pulmonary hypertension, cyanosis, failure, and arrhythmias. And then with single ventricle anatomy, the things we've stressed today have been PLE, thromboembolic disease, these AV collaterals, and cyanosis. And then, of course, when you're dealing with an adult, there's adult diseases and comorbidities that come into play. But I find that diagram very, very useful. It's the Chassot article here from 2006, as that sort of pulls it all together for us. And so it's important for us to look at these comorbidities we've discussed today. What is the venous portal hypertension? What is the systemic venous pressures? Is there something on the echo or the last cath that can guide us? Does this patient have arrhythmias? Are they on arrhythmia meds? Have they had any thromboembolic disease? Are they on anticoagulants? Because that could determine whether you're able to do a regional anesthetic or not. Do they have protein-losing enteropathy? Sometimes they have just severe right pressures and distended liver, and the gut doesn't work well. So nil per os times, although it may be 12 hours, the gut may still be full. You have to consider rapid sequence induction in some of these patients. Do they have a pacemaker in situ? Is it working? Has it been tested? Those become key things for us. Is it an anatomical left or right ventricle? What is their function? Can they get around? What are they able to do? Is it fenestrated or not? If the Fontan is fenestrated, you'd expect them to have a lower saturation, but they may have a better cardiac output. If there's no fenestration, the sats may be high, but if we develop any pulmonary hypertension or we don't ventilate them well, or we may get into trouble with cardiac output and decreased transpulmonary gradient of blood and decreased cardiac output that way. So, you want to look at is there a recent echo? Have they seen cardiology recently? Are they optimized? Should they be admitted for elective surgery, some diuretics, maybe some ACE inhibitors? Do they need some inotropes during the surgery? Do they need invasive monitoring? Those become factors looking at the substrate and determining what procedure they're going for. The ECG is often very difficult to develop in single ventricle anatomy. You can't really see ST segment depression. There's bundle branch blocks, so they may not always be very easy to determine. The other thing which we often think about is, well, single ventricle patients at altitude do badly, and we sort of have this myth. But this paper came out in 2013 where they compared patients in Denver, Edmonton, which was much lower, 660 meters, Toronto 103 meters, essentially sea level. And they really found that the Fontan failure rate in all of them was about the same. Altitude was not influencing a greater failure rate. And at cath, it didn't seem to affect pulmonary artery pressures, transpulmonary gradients, pulmonary vascular resistance, or ventricular end diastolic pressures. Nor did it have any influence on the decrease from the pre-Glenn to the Fontan catheterization assessments, nor on palliation failures. What really determined outcome in all of these patients was the underlying pulmonary vascular resistance and pulmonary artery pressures. If they were favorable in that regard, if they had low pulmonary vascular resistance and low pressures, they were the ones who were going to do much better. So I've just set this up as a sort of a quick scenario. Just let's finish off with a case. A 43-year-old tricuspid atresia, had a Fontan in childhood. He's now presenting for laparoscopic cholecystectomy and the SATs are 90. This is something we see commonly. High turnover of red blood cells in congenital heart disease, lots of bilirubin to deal with. They get pigment, gallstones. They need cholecystectomies. So it's important. Try and look at the records. Pediatric to adult care transition. How has this patient done? What type of Fontan might they have had 35 odd years ago? What's their myocardial function like? Their comorbidities? His diuretics? Is he on ACE inhibitors? What's his potassium? Any arrhythmia potential? Blood pressure? It's important to see if he's fenestrated or not. If he's not fenestrated and his SATs are 90, that's a worry. There's probably some collaterals in the lung. If he is fenestrated, 90 wouldn't be a problem. Think about what type of ventilation we're going to do. Or we're probably going to have to paralyze this patient, intubate them. They're going to be in Trendelenburg, anti-Trendelenburg. What's the pneumoperitoneum effects going to be? They actually tolerate pneumoperitoneum pretty well because it maintains the SVR. The other important thing is, when do they last see a cardiologist? What's their function like? The post-op care, where are they going to go? Do we need an arterial line? I think it depends on the underlying myocardial substrate. If there's poor function, Dr. Schwartz has written on it and described a patient having renal transplant who it was very helpful to use a transesophageal echo during the procedure. So there may be other ways to monitor myocardial function during the procedure in challenging cases. So really we just want to preserve the myocardial function. We don't want to do anything that's going to make them worse. We think about the thrombotic risk, central lines, inotropes, endocarditis prophylaxis. Graded neuraxial anesthetic is very reasonable, but if they're on warfarin, you may need to stop that, bridge them to heparin. It all depends on what the procedure is and whether there would be a benefit from a regional procedure, but there often is. And we need to control the SVR and prevent hypoxia. The single ventricle parturient, this is a very Difficult area. These patients don't do well. Their offspring don't do well. There's a high abortion rate, spontaneous abortion in single ventricle anatomy patients. And it's been estimated, I'm not sure if Joy's here, or somebody from obstetrics, but it's been estimated that 25% of maternal cardiac deaths are now involve congenital heart disease patients. So as we've improved the outcome of congenital heart disease patients, so they've wanted to have families, rightly so. But the underlying cyanosis and single ventricle anatomy does predispose them to high risk. The future directions, some of these poor patients end up going on to heart and or liver transplant. There are a few centers which are doing them. Stanford is one on block. There are 47 publications on Fontan mechanical support devices currently. And these implants are based on the von Karman viscous pump, which can be placed percutaneously almost. And this pump is ideally going to be situated at the bifurcation of the pulmonary arteries, the SVC and the IVC. And it's held together in this cage-like structure and allowed to spin. And this will allow then augmentation of venous return from the SVC and the IVC into those pulmonary arteries. And it's just felt that this just raises the pressure by 2 or 3 millimeters to drive that blood through the lungs. And this is hopefully over time, as one of these types of technology emerge, they will bring some hope to some of our patients who have a failing Fontan. So I thank you for your attention. We've described the early work that led to Dr. Fontan developing total pulmonary operation. We've looked at the long-term extracardiac consequences. We understand how the Fontan ventricle fails, and we have some approach to the anesthetic considerations in these patients. Thanks very much. Any questions? Thank you.
One thing we should also mention is that although Blaylock and Castle got all the credit, it was Vivian Thomas who actually did the...
Correct. Dr. Yaster reminds us, Vivian Thomas with Blaylock and Tarsing, we should have mentioned that. He was the unsung hero of that era. And there's a wonderful video, Something the Lord Hath Made, which describes his life, and it's worth seeing. I think it's on Netflix or Amazon Prime.